Question 1. Molecular diagnostic techniques. A patient presents with a suspected autosomal recessive disorder known to be associated with a single nucleotide variant. The clinician requests a molecular test that will provide high sensitivity and specificity for detecting single nucleotide changes at a low cost. Which of the following is the most appropriate test to order? A. Southern blot. B. Next generation sequencing (NGS). C. Sanger sequencing. D. Fluorescence in situ hybridization FISH. Answer: C. Sanger sequencing. Explanation: Sanger sequencing is the gold standard for detecting single nucleotide variants (SNVS) with high accuracy. It provides excellent sensitivity and specificity for small-scale targeted analysis and is cost-effective when testing a small number of genes. A. Southern blot is primarily used for detecting large genomic rearrangements and ENA ethylation changes, but is not suitable for detecting SNVS. A. NGS is highly effective for large-scale genetic screening, but it is more expensive and may have limitations in detecting certain sequence variants with low coverage. D. FISH is used for detecting large chromosomal abnormalities, such as deletions or translocations, but it does not provide nucleotide-level resolution. This aligns with guidelines, which recommend Sanger sequencing for confirming SNVS identified in diagnostic panels or as a standalone test for known single-gene disorders. Question 2. Clinical cytogenetics, scenario-based. Dr. Patel, a geneticist, is evaluating a 6-year-old male patient with developmental delay, hypotonia, and distinctive facial features. His parents report speech delays and difficulty with feeding during infancy. A karyotype analysis was performed showing a microdeletion in chromosome 15. Given the clinical presentation, what is the most appropriate next step to confirm diagnosis? A. Repeat karyotyping at a higher resolution. B. Chromosomal microarray CMA. C. Methylation-specific PCR. D. Whole exome sequencing. Answer: C. Methylation-specific PCR. Explanation: The clinical features described are suggestive of either Prader-Willi syndrome (OBUS) or Angelman syndrome, as both of which are caused by alterations in chromosome 15q. SNRBUSANs involve imprinting defects. Methylation-specific ECR is the most appropriate confirmatory test. A. Repeat karyotyping at a higher resolution may detect large deletions but lacks the ability to identify imprinting defects. B. Chromosomal microarray CMA is useful for detecting copy number variations but does not distinguish between senders. D. Whole exome sequencing, whereas is typically used for single gene disorders and would not be the first-line test for an imprinting disorder. According to guide, methylation-specific ECR should be the primary diagnostic tool for imprinting disorders at ERBSNs. Question 3. Pharmacogenomics and precision medicine. A 45-year-old patient with colorectal cancer is prescribed 5-fluoroacyl-5-FU as part of their chemotherapy regimen. Prior to initiating treatment, the oncologist orders pharmacogenetic testing to assess the patient's risk for severe toxicity. Which gene should be analyzed to guide drug dosing? A. ERCA. E. DPID. E. MLH. D. AP. Answer: B. DPID. Explanation: DPID dihydropyrimidine dehydrogenase gene variants are known to impact the metabolism of 5-FU. Patients with DPID mutations may have reduced enzymatic activity, leading to severe toxicity, including myelosuppression, neurotoxicity, and mucositis. AUREA is related to hereditary breast and ovarian cancer, but has no role in fluoropyrimidine metabolism. C. MH is associated with Lynch syndrome, a hereditary colorectal cancer condition, but does not affect 5-FU metabolism. D. APCAS, a tumor suppressor gene frequently mutated in colorectal cancer, but it does not play a role in drug metabolism. According to Clinical Pharmacogenetics Implementation Consort (CPIC) guidelines, patients with DPID deficiency should receive either a reduced 5-FU dose or an alternative treatment to prevent severe adverse effects. Question 4. Epigenetics and genomic imprinting. A newborn presents with hypotonia, failure to thrive, and characteristic facial features. A geneticist suspects Beckwith-Wiedemann syndrome (OBUS) or Silver-Russell syndrome (SRS), both of which involve imprinting defects on chromosome 11.5. The physician orders genetic testing. Which of the following best explains why disorders involving imprinting defects can present with phenotypes despite affecting the same genomic region? A. Random exon activation in females leads to variable expression of the imprinted genes. B. Genomic imprinting leads to differential parent of origin specific expression of certain genes. C. Autosomal dominant inheritance leads to variable expressivity in affected individuals. D. The mutation rate in imprinting regions is higher than in other parts of the genome, leading to phenotypic variability. Answer: B. Genomic imprinting leads to differential parent of origin specific expression of certain genes. Explanation: genomic imprinting is a process in which specific genes are expressed based on whether they were inherited from the mother or father. Disorders rest involve abnormalities. Chromosome 11.5, which contains imprinted genes such as IGFNH. A random X inactivation affects only X-linked genes and is irrelevant for autosomal imprinting disorders. C. Autosomal dominant inheritance is not involved here, as imprinting disorders follow a unique inheritance pattern. D. The mutation rate in imprinting regions is not inherently higher, but rather the key issue is epigenetic regulation. The European Society of Human Genetics recommend methylation-specific tests to confirm imprinting defects in suspected case at Elorus. Question 5. Chromosomal microarray versus karyotyping scenario-based. Dr. Anderson, a geneticist, evaluates a 3-year-old female with global developmental delay, hypotonia, and dysmorphic features. The patient has no family history of genetic disorders. The initial karyotype is normal. The parents ask whether additional testing is necessary. What is the most appropriate next step in the genetic evaluation of this patient? A. Whole genome sequencing. B. Chromosomal microarray CMA. C. Fluorescence in situ hybridization FISH. D. Targeted single gene testing based on clinical suspicion. Answer: B. Chromosomal microarray CMA. Explanation: for children with developmental delay, intellectual disability, or autism spectrum disorder, the first-line genetic test recommended by the American College of Medical Genetics is chromosomal microarray analysis (CMA). CMA can detect submicroscopic copy number variations (CNVS) that traditional karyotyping would miss. A whole genome sequencing is comprehensive but expensive and not typically first line for developmental disorders. C. FISH can detect specific deletions, e.g. 20.2 deletion in DiGeorge syndrome, but is not the best general screening tool. D. Targeted single gene testing is useful when a specific syndrome is strongly suspected, but CMA is preferred for an initial broad evaluation. According to Guide, CMA is the standard of care test for unexplained neurodevelopmental disorders. Question 6. Inheritance patterns in cardiovascular genetics. A 22-year-old male presents with aortic root dilation and a positive family history of aortic dissections. Genetic testing identifies a pathogenic variant in the FBN gene. His physician explains the mode of inheritance and recurrence risk to his family members. Which of the following best describes the inheritance pattern of this condition? A. Autosomal recessive with a 25% recurrence risk for siblings. B. X-linked dominant with male lethality. C. Autosomal dominant with variable expressivity. D. Mitochondrial inheritance passed only through the mother. Answer: C. Autosomal dominant with variable expressivity. Explanation: Marfan syndrome, caused by pathogenic variants in FBN, follows autosomal dominant inheritance with variable expressivity, meaning individuals can have different severities of symptoms. A. Autosomal recessive disorders require 2 pathogenic variants, but Marfan syndrome is dominant. B. X-linked dominant with male lethality describes Rett syndrome, not Marfan syndrome. D. Mitochondrial inheritance only involves maternal transmission, which is not the case for FBN-related disorders. The American Heart Association I recommend early cardiovascular screening for at-risk family members to life-threatening aortic complications. Question 7. Variant interpretation in molecular diagnostics. A laboratory receives a genetic sequencing result for a patient with suspected hereditary breast and ovarian cancer HBOC. The patient has a variant of uncertain significance. Thus, what is the most appropriate next step? A. Recommend prophylactic mastectomy and oophorectomy. B. Reclassify the variant as pathogenic based on the patient's family history. C. Perform family studies and functional assays to assess variant significance. D. Disregard the variant as it is not clearly pathogenic. Answer: C. Perform family studies and functional assays to assess variant significance. Explanation: a variant of uncertain significance thus means that the clinical impact of the genetic change is not yet established. According to guidelines, further studies, G. Segregation analysis, functional assays, and population data should be conducted before making clinical decisions. A. Prophylactic surgery is recommended only for pathogenic pathogenic variants. B. Reclassifying a VUS as pathogenic without strong evidence is inappropriate. D. Ignoring a VUS is also incorrect. Monitoring and re-evaluation are necessary. The ICMM framework requires additional evidence before reclassification. Question 8. Pharmacogenetics in warfarin dosing. A 68-year-old female is prescribed warfarin for atrial fibrillation. Genetic testing identifies the CYP3 allele and the VUC163 linear variant. How should her warfarin dosage be adjusted based on this result? A. No adjustment is necessary, as these variants do not affect warfarin metabolism. B. Increase the initial dose due to reduced warfarin sensitivity. C. Decrease the dose as these variants lead to increased warfarin sensitivity. D. Switch to a direct oral anticoagulant as warfarin is contraindicated in sick carriers. Answer C. Decrease the dose as these variants lead to increased warfarin sensitivity. Explanation: the CYP3 variant results in reduced warfarin metabolism, while VUC163 NINI increases sensitivity to warfarin. Patients with these variants require a low warfarin dose to avoid excessive anticoagulation. A. No adjustment is incorrect. Genetic variants do impact warfarin dosing. B. Increasing the dose would increase the risk of bleeding. D. Switching anticoagulants is not necessary solely due to these genetic factors. According to CPIC guidelines, warfarin dosing should be tailored based on genetic and clinical factors to reduce bleeding risk. Question 9. Mitochondrial disorders and inheritance patterns. A 7-year-old male presents with progressive muscle weakness, lactic acidosis, and neurological symptoms. His mother has a history of exercise intolerance and mild ataxia. The physician suspects a mitochondrial disorder. Which of the following best describes the inheritance pattern of this condition? A. Autosomal dominant with 50% risk for offspring. B. X-linked recessive, affecting males more severely. C. Mitochondrial inheritance, transmitted only from the mother. D. Autosomal recessive, requiring 2 pathogenic variants. Answer C. Mitochondrial inheritance, transmitted only from the mother. Explanation: mitochondrial disorders are exclusively maternally inherited, as mitochondria are transmitted only through the egg cell maternal cytoplasm. Classic mitochondrial diseases include Leigh syndrome, Meller's mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes, and Leber's hereditary optic neuropathy. Lon. A. Autosomal dominant inheritance does not apply, as mitochondrial disorders are not passed through nuclear DNA. B. X-linked recessive disorders. E.g. Duchenne muscular dystrophy affect males more frequently but do not involve mitochondrial DNA. D. Autosomal recessive inheritance applies to many metabolic disorders, but not mitochondrial diseases. Mitochondrial disorders often show heteroplasmy, meaning that different may have varying levels of mutant and normal mitochondrial DNA, leading to variable expressivity. Question 10. Next-generation sequencing and variant prioritization. A genetic counselor is analyzing whole exome sequencing data from a patient with early-onset epilepsy and developmental delay. Multiple variants were detected, including a novel missense mutation in SENA, a gene linked to Dravet syndrome. What is the best method to determine if this novel variant is likely pathogenic? A. Assess population allele frequency in silico predictions and functional studies. B. Assume the variant is benign since it has not been reported in databases. C. Order chromosomal microarray CMA to confirm the mutation. D. Use PCR to verify the sequencing result and confirm inheritance. Answer A. Assess population allele frequency in silico predictions and functional studies. Explanation: variant classification follows in guidelines which recommend evaluating population allele frequency no man exact. If the variant is common, it is unlikely pathogenic. In silico predictions, SIFT, Polyphon, CAD, these tools predict the functional impact of the mutation. Functional studies and segregation analysis, evidence from FUN, SAYS or family studies can help determine pathogenicity. B. Assuming the variant is benign is incorrect because novel variants require investigation. ECMA detects copy number variations, CNBS, but does not confirm single nucleotide variants, SNBS. The ECR confirmation is useful for technical validation but does not determine pathogenicity. According to inclusion, a variant should be classified based on multiple lines of evidence. Question 11. Newborn screening and false positives. A newborn screens positive for cystic fibrosis (CF) via immunoreactive trypsinogen testing. However, genetic testing reveals only one pathogene KETI mutation. What is the most appropriate next step? A. Perform a sweat chloride test to confirm CF diagnosis. B. Inform the parents that the child definitively has CF. C. Assume the result is a false positive and discontinue follow-up. D. Order exome sequencing to identify additional mutations. Answer: A. Perform a sweat chloride test to confirm CF diagnosis. Explanation: newborn screening for CF involves testing which has a high false positive rate. A sweat chloride test is the gold standard for diagnosing CF. B. Informing the parents that the child definitively has CF is incorrect. Diagnosis requires further confirmation. C. Disregarding the positive newborn screen is inappropriate since follow-up is necessary. D. Exome sequencing is not required unless there is strong clinical suspicion of atypical CF. And CF Foundation guidelines recommend confirmatory sweat testing, NCAR sequencing in borderline cases. Question 12. Cancer genetics and Lynch syndrome. A 35-year-old woman is diagnosed with colorectal cancer. Her family history includes multiple cases of early-onset colorectal and endometrial cancers. Her tumor undergoes microsatellite instability (MI) testing, which shows high instability (MSEH). Which genetic test is most appropriate? A. ER-Caboca sequencing at MS8 and AMS sequencing. C. TP mutation analysis. D. Whole genome sequencing. Answer: MS sequencing. Explanation: Lynch syndrome, hereditary non-polyposis colorectal cancer (HAIA) is associated with mutations in MS8 and AMS, which are RNA mismatch repair (MMSIT) genes. MSIH tumors strongly suggest a deficiency in MMSAD genes. A. BR-Caboca testing is for hereditary breast and ovarian cancer (HBOC). C. TP mutations are associated with Li-Fraumeni syndrome, which includes various cancers but not MSIH colorectal cancer. D. Whole genome sequencing is not first line for hereditary cancer syndromes. NCCN guidelines recommend MMSIT gene sequencing for MSIH tumors. Question 13. Carrier screening in reproductive genetics. A 28-year-old woman is planning pregnancy and requests genetic carrier screening. She is Ashkenazi Jewish and has no family history of genetic conditions. What is the most appropriate genetic test? A. Whole genome sequencing. B. Targeted carrier screening for conditions common in Ashkenazi Jewish populations. C. Karyotype analysis. D. Mitochondrial DNA sequencing. Answer: B. Targeted carrier screening for conditions common in Ashkenazi Jewish populations. Explanation: carrier screening is population-specific for autosomal recessive conditions. For Ashkenazi Jewish individuals, recommended testing includes Tay-Sachs disease, hexagene, Gaucher disease, DBA-DIN, cystic fibrosis, CETR-DIN, Canavan disease, Bloom syndrome, Niemann-Pick disease. A. Whole genome sequencing is unnecessary for routine carrier screening. C. Karyotyping detects chromosomal abnormalities, but not single gene disorders. D. Mitochondrial DNA sequencing is not relevant for recessive conditions. The ACOG and recommend ethnicity-based carrier screening in reproductive settings. Question 14. Whole exome sequencing in a child with developmental delay. A 3-year-old male presents with global developmental delay, hypotonia, and facial dysmorphism. Previous chromosomal microarray CMA and Fragile X testing were normal. The neurologist orders whole exome sequencing (WES). The results identify a novo missense variant in a gene associated with neurodevelopmental disorders, classified as a variant, has certain significance. Thus, what is the next best step in evaluating this variant? A. Parental testing to determine inheritance. B. Reassure the parents that the variant is likely benign. C. Order whole genome sequencing for additional findings. D. Perform a karyotype to check for structural abnormalities. Answer: A. Parental testing to determine inheritance. Explanation: the VUS requires further evaluation before it can be classified as pathogenic or benign. Parental testing helps determine whether the variant is novo, more likely pathogenic if absent in parents, inherited, suggesting it may be benign if present in a healthy parent. B. Reassuring parents without further investigation is incorrect because the pathogenicity is still uncertain. Whole genome sequencing may identify additional variants but is not the first step in VUS evaluation. D. Karyotyping is not relevant for single nucleotide variants SNVS. According to guidelines, family segregation analysis is crucial in variant classification. Question 15. BR-Kevoca testing in a young woman with breast cancer. A 32-year-old woman is diagnosed with triple-negative breast cancer (TNEC). Her mother was diagnosed with ovarian cancer at 45, and her maternal aunt had breast cancer at 40. Which genetic test is most appropriate for this patient? A. BR-Kevoca genetic testing. B. Microsatellite instability (MI) testing. C. Chromosomal microarray (CMA). D. Mitochondrial genome sequencing. Answer: AER-Kevoca genetic testing. Explanation: women with early onset breast cancer, particularly TNEC, have an increased likelihood of BR-Kevoca mutations. EREA mutations are strongly linked to TNEC, and ovarian cancer. BRCA mutations are associated with breast and pancreatic cancers. BMI testing is used for colorectal and endometrial cancers associated with Lynch syndrome. CCMA is for copy number variants but is not used for hereditary cancer syndromes. Deep mitochondrial sequencing is not relevant for breast cancer genetics. The SEN guidelines recommend ER-Kevoca testing for young patients with TNEC or a family history of hereditary breast and ovarian cancer syndrome (HBOC). Question 16. Pharmacogenomics and warfarin sensitivity. A 65-year-old man is prescribed warfarin for atrial fibrillation. Genetic testing reveals that he has variants in SIPC and VCORC associated with warfarin sensitivity. How should this information guide his treatment? A. Start with a lower initial warfarin dose and monitor inner closely. B. Increase the initial warfarin dose to compensate for metabolism. C. Switch to a different anticoagulant that does not require monitoring. D. Ignore the genetic results and follow standard dosing guidelines. Answer: A. Start with a lower initial warfarin dose and monitor inner closely. Explanation: SIPC variants reduce warfarin metabolism, leading to increased drug levels. VCORC variants decrease vitamin K recycling, making patients more sensitive to warfarin. These genetic factors require a lower starting dose to prevent excessive anticoagulation and bleeding risk. B. Increasing the dose would heighten bleeding risk. C. Switching to an anticoagulant may be an option, but is not necessary based on pharmacogenomic results alone. D. Ignoring the results could lead to over-anticoagulation and bleeding complications. Clinical guidelines. CPIC recommend genotype-guided warfarin dosing. Question 17. Carrier screening for cystic fibrosis in an interracial couple. A Caucasian woman and her African-American partner are planning pregnancy. The woman tests positive as a mutation carrier. What is the most appropriate next step? A. Offer EAR gene testing to the male partner. B. Assume the risk is low and proceed with pregnancy. C. Recommend karyotyping for both partners. D. Perform amniocentesis immediately. Answer: A. Offer EAR gene testing to the male partner. Explanation: cystic fibrosis (CF) is an autosomal recessive condition, meaning both parents must be carriers for the child to be affected. Carrier frequency differs by ethnicity, but testing is still necessary in partners of different backgrounds. B. Assuming low risk is incorrect without confirming the partner's carrier status. C. Karyotyping detects chromosomal abnormalities, but if relevant for CF. D. Amniocentesis is not indicated unless both parents are confirmed carriers. ACOG guidelines recommend carrier screening in both partners. Question 18. Whole genome sequencing for a rare disorder. A 12-year-old boy has progressive neurodegeneration, ataxia, and seizures. Prior exome sequencing was inconclusive. The physician now recommends whole genome sequence diblodes. What is the advantage of diblodes over BOR? Diblodes detects intronic and regulatory region variants not covered by Web. Diblodes less expensive than Diblodes, more targeted and efficient than what diblodes and detects structural variants, not single nucleotide variants. Answer: Diblodes detects intronic and regulatory region variants not covered by WES. Explanation: whole exome sequencing WES focuses on protein coding regions 1.5% of the genome. Whole genome sequence diblodes covers intronic mutations, which may affect splicing, regulatory regions, which impact gene expression, structural variants not detected by diblodes or expensive than diblodes are broader, not more targeted than diblodes detects both single nucleotide variants SNVS and structural variants is used for when WES fails to identify a causal variant. Question 19. Pharmacogenomics in psychiatry. A patient with major depressive disorder is prescribed fluoxetine esria. Pharmacogenetic testing shows that she is a poor CYP metabolizer. What is the best clinical approach? A. Consider a lower dose or alternative medication. B. Increase the fluoxetine dose to compensate. C. Disregard the result and monitor for side effects. D. Switch to a benzodiazepine for long-term management. Answer: A. Consider a lower dose or alternative medication. Explanation: CYP poor metabolizers have higher drug levels, increasing side effects and toxicity risk. Alternative options include sertraline or escitalopram, which are less dependent on CYP. B. Increasing the dose would worsen side effects. C. Ignoring the results may lead to adverse reactions. D. Benzodiazepines are not first line for major depression. CPIC guidelines dose adjustments or alternative medications based on CYP status. Question 20. Expanded carrier screening in a multi-ethnic couple. A 28-year-old Ashkenazi Jewish woman and her 30-year-old African-American husband are planning to conceive. She undergoes expanded carrier screening X and is found to be a carrier for Tay-Sachs disease. What is the next best step in managing their reproductive risk? A. Offer Tay-Sachs disease carrier testing to the husband. B. Recommend in vitro fertilization with pre-implantation genetic testing (PGT). C. Reassure the couple that Tay-Sachs disease is rare in African Americans. D. Proceed with pregnancy and perform amniocentesis at 16 weeks. Answer: A. Offer Tay-Sachs disease carrier testing to the husband. Explanation: Tay-Sachs is an autosomal recessive disorder, meaning both parents must be carriers for the child to be affected. While Tay-Sachs is most common in Ashkenazi Jews, it also occurs in other ethnic groups, including African Americans. Testing the husband determines if the couple is at risk. B. If with PGT is an option only if both parents are carriers. C. Assuming low without testing the husband is inappropriate. D. Amniocentesis is not indicated unless the fetus is at confirmed risk. According to ACOG guidelines, carrier screening should be ethnicity-based or expanded for all couples. Question 21. Genetic testing for hypertrophic cardiomyopathy. A 45-year-old man presents with exertional dyspnea, syncope, and a family history of sudden cardiac death. An echocardiogram reveals left ventricular hypertrophy (LVH) without chamber dilation. Which genetic test is most appropriate? A. Next-generation sequencing (NGS) panel for cardiomyopathy genes. B. Carrier IPing. C. Whole exome sequencing. Whereas D. Fish for 20 talk.2 deletion. Answer: A. Next-generation sequencing (NGS) panel for cardiomyopathy genes. Explanation: HCM. A genetic disorder often caused by mutations in sarcomere genes e.g. MIPK. An NGS panel targeting cardiomyopathy genes is the most efficient and cost-effective test. B. Karyotyping is used for chromosomal disorders, no HCM. C. WES is broader but less targeted than NGS cardiomyopathy panel. D. Fish for 20 talk.2 deletion is used for DiGeorge syndrome, no HCM. Genetic testing helps confirm the diagnosis and guide family screening. Question 22. Pharmacogenomics and clopidogrel resistance. A 55-year-old man with a history of myocardial infarction undergoes percutaneous coronary intervention (ECI) with stent placement. He is prescribed clopidogrel, Plavix, but genetic testing shows he is a sick poor metabolizer. What is the best clinical action? A. Switch to an alternative antiplatelet e.g. prasugrel or ticagrelor. B. Increase the clopidogrel dose. C. Continue clopidogrel with close monitoring. D. Stop antiplatelet therapy altogether. Answer: A. Switch to an alternative antiplatelet e.g. prasugrel or ticagrelor. Explanation: sick poor metabolizers cannot efficiently convert clopidogrel to its active form, leading to reduced antiplatelet effect and higher risk of stent thrombosis. B. Increasing the dose will not compensate for the poor metabolism. C. Monitoring will not prevent inadequate drug activation. D. Stopping antiplatelet therapy would increase the risk of thrombosis. Guidelines from CPIC and ACAHA recommend prasugrel or ticagrelor in sick poor metabolizers. Question 23. Whole exome sequencing for a child with intellectual disability. A 6-year-old girl presents with global developmental delay, intellectual disability, and dysmorphic features. Previous chromosomal microarray CMA was normal. The neurologist recommends whole exome sequencing, whereas what is the primary advantage of WES in this case? A. Identifies single nucleotide variants SNVS not detected by CMA. B. Detects large chromosomal rearrangements. C. Primarily used for mitochondrial disorders. D. Less expensive than chromosomal microarray. Answer A. Identifies single nucleotide variants SNVS not detected by CMA. Explanation: West detects SNVS and small insertions deletions encoding regions that CMA cannot identify. BCMA is better for large deletions duplications, but WES is superior for gene mutations. C. Mitochondrial sequencing is more targeted for mitochondrial disorders. D. WES is more expensive than EMA, but greater diagnostic yield. According to guidelines, WES is the next step after a negative CMA. Question 24. Lynch syndrome and colon cancer screening. A 38-year-old woman is diagnosed with colorectal cancer. Her father had colorectal cancer at 42, and her aunt had endometrial cancer at 45. Immunohistochemistry of her tumor shows loss of MH and EMS expression. What is the most appropriate next step? A. Perform germline genetic testing for Lynch syndrome. B. Repeat colonoscopy in 5 years. C. Test for BRAF-V mutation. D. Recommend colectomy without further testing. Answer A. Perform germline genetic testing for Lynch syndrome. Explanation: Loss of MH and EMS suggests a mismatch repair defect consistent with Lynch syndrome. C. BRAF testing is used to distinguish sporadic-deficient tumors, but germline testing is necessary first. B. Delaying colonoscopy is inappropriate in high-risk individuals. D. Colectomy may be considered but requires genetic confirmation and guide. Recommend Lynch syndrome testing in young colorectal cancer patients. Question 25. Nipped and confined placental mosaicism. A 32-year-old pregnant woman undergoes non-invasive prenatal testing (NIPT), which shows a trisomy 13 result. Ultrasound findings are normal. What is the best next step? A. Perform diagnostic testing via chorionic villus sampling, CVS, or amniocentesis. B. Assume the fetus is affected and prepare for neonatal complications. C. Recommend termination of pregnancy. D. Repeat NIPT in 4 weeks. Answer A. Perform diagnostic testing via chorionic villus sampling, CVS, or amniocentesis. Explanation: NIPT is a screening test and can yield false positives due to confined placental mosaicism (CPM). B. Assuming the fetus is affected is incorrect without diagnostic confirmation. C. Termination should not be considered until diagnostic testing is performed. D. Repeating NIPT does not confirm or exclude a true abnormality. According to COG guidelines, abnormal NIPT results should be confirmed with invasive testing. Question 26. BRCA testing in breast cancer management. A 42-year-old woman is diagnosed with triple-negative breast cancer (TEC). Her mother had ovarian cancer at age 50. Given her family history, the oncologist recommends BRCA genetic testing. If she tests positive for evaluation, what are the most appropriate next steps? A. Offer bilateral mastectomy and risk-reducing salpingo-oophorectomy. B. Continue routine breast cancer surveillance. C. Test for additional mutations using whole genome sequencing. D. No further interventions are necessary. Answer A. Offer bilateral mastectomy and risk-reducing salpingo-oophorectomy. Explanation: ERCA mutations are associated with a high lifetime risk of breast 70% and ovarian 40% cancer. Bilateral mastectomy reduces breast cancer risk and RO is recommended by age 3540. B. Surveillance alone is not sufficient for urea carriers. C. Whole genome sequencing is not standard. Clinical decision-making. D. Interventions are necessary due to high cancer risk. NCCN guidelines recommend risk-reducing surgery for urea carriers. Question 27. Pharmacogenomic testing for warfarin sensitivity. A 65-year-old man with atrial fibrillation is started on warfarin for stroke prevention. He has a history of easy bruising and prolonged inner response. Genetic testing reveals he is a carrier of the VCORC1639 allele and CYP3 variant. How should his warfarin therapy be adjusted? A. Start with a lower dose of warfarin. B. Start with a higher dose of warfarin. C. Switch to a direct oral anticoagulant dose. D. Discontinue anticoagulation therapy. Answer A. Start with a lower dose of warfarin. Explanation: VCORC1639 and CYP3 are associated with warfarin sensitivity, increasing bleeding risk. B. Higher doses would increase inner and risk hemorrhage. C. Doses are an option, but warfarin can still be used with dose adjustments. D. Stopping anticoagulation is not appropriate due to stroke risk. CPIC guidelines recommend lower warfarin doses for with the genetic variants. Question 28. Li-Fraumeni syndrome and TP mutation management. A 30-year-old woman is found to have an mutation after genetic testing for her family's cancer history. Her mother had breast cancer at 35 and her uncle died of adrenocortical carcinoma. What cancer surveillance strategy is recommended for her? A. Annual whole body MRI, breast MRI, and frequent clinical evaluations. B. Annual mammogram and colonoscopy only. C. No increased surveillance needed until symptoms develop. D. Annual chest CT and brain MRI, but no whole body screening. Answer: A. Annual whole body MRI, breast MRI, and frequent clinical evaluations. Explanation: Li-Fraumeni syndrome (LFS) is caused by TP mutations leading to high risks of multiple cancers, breast, sarcomas, brain, adrenocortical leukemia. B. Mammograms and colonoscopies alone are not sufficient for LFS. C. Waiting for symptoms would delay cancer detection. D. Whole body MRI is preferred over selective IM. SEN guidelines recommend aggressive surveillance in TP carriers. Question 29. Carrier screening for cystic fibrosis (CF) in pregnancy. A 29-year-old pregnant woman undergoes cystic fibrosis (CF) carrier screening and is found to carry a mutation. What is the next best step? A. Test the father for CF mutations. B. Offer ETR gene sequencing to the fetus. C. Reassure the patient that the fetus is not at risk. D. Perform chorionic villus sampling (CVS) immediately. Answer: A. Test the father for CF mutations. Explanation: CF is an autosomal recessive disorder. If both parents are carriers, the baby has a 25% chance of having CF. B. Fetal testing is only needed if the father is also a carrier. C. Reassurance is inappropriate without paternal testing. D. CVS is premature without confirming if the baby is at risk. ACOG guidelines recommend carrier screening for CF in all pregnancies. Question 30. Huntington's disease and presymptomatic testing. 25-year-old man requests genetic testing for Huntington's disease HD because his father developed symptoms at age 45. What is the most appropriate approach? A. Offer genetic counseling and presymptomatic testing. B. Perform brain imaging to check for early disease signs. C. Refuse testing until he develops symptoms. D. Proceed with genetic testing without counseling. Answer: A. Offer genetic counseling and presymptomatic testing. Explanation: Huntington's disease is an autosomal dominant disorder caused by carrying repeat expansions in HET. B. Brain imaging is not useful for asymptomatic individuals. C. Waiting for symptoms delays reproductive and life planning. D. Testing should always be preceded by genetic counseling, and guidelines recommend counseling before presymptomatic HD testing.